My name is Glenn Doherty, and I'm a gastroenterologist in St Vincent's in Dublin, but I'm the national lead for endoscopy training within the HSE endoscopy programme. And I'm pleased to be presenting the launch of this competency framework on behalf of the HSE endoscopy programme, the National Endoscopy Training Committee, and the College of Physicians and Royal College of Physicians and RCSI. So I just want to let you know that we're recording this evening's event so that we can make it available to people. I'm going to give a brief presentation to give an overview of what we've been trying to achieve by introducing the competency framework. I'm going to invite representatives from both of our colleges to make some remarks. And then we'll have a bit of a panel discussion and open things up to you, the audience, for questions and comments as well. So just want to briefly introduce the National Endoscopy Training Committee, which I chair and which is supported by the endoscopy programme. The programme manager is Grace O'Sullivan, and our training and accreditation officer is Dorothy Murray. And thanks a lot to Dorothy for all the work she's put into organising the webinar, but also bringing together this document, and to the support of Jan Layden, who's the clinical lead within the HSE endoscopy programme. And as you can see, the Endoscopy Training Committee has representatives from both the RCPI, RCSI, and the Irish Society of Gastroenterology, and we have a very broad mix of colorectal, GI, and general surgeons and gastroenterologists who've contributed to developing this approach to endoscopy training. Because when we look at the GRS returns that we first started to do the JAG Global Rating Survey in 2014, and we could see that the training domain was always the domain that we fell down in. And in fact, if we look at the GRS returns even up till 2020 and 2021, we've continued to, this tends to be the domain where we've continued to lag behind in terms of endoscopy. So when the GI endoscopy program was set up within the HSE, we wanted a specific focus on endoscopy training, and in particular we wanted to try and create a partnership approach between gastroenterology and surgery in the provision of endoscopy services, and also in the way that we delivered and improved endoscopy training nationally. So in the past, when many of us trained in GI endoscopy, we watched a couple of procedures, we read a little bit of the theory in Cotton and Williams' textbook, and then largely we learned by doing, with obviously more supervision in the beginning and then a gradual reduction in the amount of supervision that was required. But a lot of the learning was done by just by sheer quantity of sort of procedures. More recently, we've introduced DOPS evaluations to try and assist that sort of process. But really what we've had, the focus in the past was always on getting the numbers, and I guess the big shift that we're looking to make today is towards a focus on competency rather than on the number of procedures. And so this graph, I hope anyway, gives a sort of a flavour for how we see the future for training in GI endoscopy, where trainees in both gastroenterology and in general surgery begin to, by observing some procedures, possibly by using simulators as well, and then go from being assisted to perform procedures to being supervised initially very directly, and then as time goes by, more with more hands-off degree of supervision, until such time as they achieve a satisfactory level of competence where they're deemed to be competent for an independent practice in a particular procedure, whether that's upper or lower GI endoscopy. And they receive a provisional approval process, a bit like their R plates or their N plates, where they can go on then to continue within the training program to perform endoscopy, but very much in a model of mentored practice. So they're still being supervised. There's more focus on key performance indices, but it's really about them consolidating their ability to perform procedures independently, which should hopefully coincide then with the completion of their training, their respective training scheme. So we're moving our focus away from numbers, but we have kept some suggested or recommended targets for the number of procedures that people should perform ideally in order to achieve competency. And when we look at, and there's a number of manuscripts that have shown very similar results, that the number of, say, colonoscopies, which on average people need to do to achieve competency, is roughly about 200. You will certainly have some trainees who will be competent after doing 100 or 150 colonoscopies, and then a small number of people who will need to perform 300, 400, maybe even 500 colonoscopies before they're fully competent. And that's why I think we want to make the shift away from a focus on numbers to a focus on competency, but with an awareness that somewhere around 200 remains a sort of a recommended benchmark for people. So moving away from measuring numbers, we want to measure competency, and that's where DOPS evaluations perform a key role. And there's a suite of DOPS evaluation forms for gastroscopy, colonoscopy, and also to support training in polypectomy techniques and techniques of endoscopic hemostasis, which are incorporated within the competency framework document, which we're launching this evening. And as you can see, we've moved very much from a system where we used to grade people's level of skill as, you know, satisfactory or unsatisfactory, towards really the focus now being what level of supervision do people require, or have they reached a level where no supervision is required and they're competent for independent practice. And you can see that that applies right the way through from before the procedure, during the procedure, after the procedure, and then the broad, what we call endoscopic non-technical skills, which are assessed, which are so important in how we work together as a team in the endoscopy unit. The other key thing that underlines our approach to operating the competency model is the KQI data. And there's obviously a real focus on making sure that all of our trainees become registered, but also that all of our trainers are registered and are looking regularly at their KQI data as part of their own performance evaluation, both as an individual reflecting on one's own practice, then at a unit level, and obviously we produce a national QI report for GI endoscopy on an annual basis every year now. So just to summarize the suggested conditions for granting this provisional approval, which is allows a trainee for an individual procedure then to perform this procedure independently while still within their training program. So we're still suggesting 200 as a minimum number, but it's a suggestion, not a mandatory figure, because the focus really is on the importance of completing a number of DOPS evaluations which demonstrate that the individual is competent for independent practice in that procedure. Both a number of formative procedures in the run-up to the approval process, and then a summative procedure for either upper or lower GI endoscopy. And I'll talk a little bit more about some of the endoscopy training courses that we've developed to support the rollout of the competency framework. So this is the sort of form that we're suggesting needs to be completed to document the provisional approval process. Pretty straightforward, just documenting that a certain number of procedures has been completed, that the NQI records have been reviewed, and that the appropriate DOPS evaluations have been performed, and the trainee, the trainer within the named trainer within the training program, and then the unit training lead sign this off at a unit level. And that allows a degree of protection for both the trainer and trainee, that if a trainee is then in a room performing a procedure and has a complication, and there are questions asked about either their level of skill or their level of supervision, that this puts all of this on a more protected framework. The final certification process is then completed when the trainee is coming towards the end of their training program. Ideally, I think probably in the penultimate year, but possibly also some people may need to wait until their final year to complete this final sign-off procedure. And this is broadly equivalent to, in the UK, the JAG certification process for sign-off or certification of endoscopists. So in order to make a meaningful evaluation of people's KPI data, we're suggesting an additional 100 procedures after the provisional approval process. Then the completion of a final summative DOPS evaluation, once again showing that the individual still shows skills that are competent for independent practice, and then bringing in for the final certification a degree of competency in the management of GI bleeding and removal of polyps up to 2 centimeters in size, and once again a number of mandatory and highly recommended courses. And then this is very similar again, the record for final certification, in this case signed off by the trainee and trainer, but now going to the level of the training program director for final sign-off. So the STEPS program was something that we put together to try and bring existing training courses in GI endoscopy under the one umbrella, trying to sort of standardize the content and delivery of courses, and also to involve both of the colleges. So the basic skills course, which we've just completed delivering an online basic skills course this afternoon, and the hands-on colonoscopy skills course, which is both of these courses open to trainees in both colleges. The basic skills and hands-on colonoscopy skills currently operated by RCPI, and the GI bleeding course and the in development polypectomy skills course will be delivered by RCSI, and it's one aspect of this program that I'm particularly proud of is that we've managed to involve both colleges in a very collaborative way, and we've been very impressed by the level of support and commitment from both colleges to deliver this skills training program. The other thing, as well as an educational ask for the trainees, is supporting our trainers to be able to deliver these courses. We've developed a hands-on colonoscopy excellence course for consultants and the colonoscopy trainer course for consultants. And obviously during COVID, we haven't been able to deliver any of these hands-on courses, but I'm pleased to say that in 2 weeks' time, we'll be restarting our colonoscopy excellence course for consultants, which will be running in St. Vincent's for the first time in 2 years. So this is one of our hands-on courses that we were very pleased to be able to run just 2 weeks ago in the Surgical Skills Lab in RCSI. We had a group of 50% gastroenterology and 50% general surgery trainees. We had some very interactive case-based discussions and a number of very stimulating live stations using porcine stomach models to demonstrate a lot of the endoscopic techniques that are important in control of hemostasis. And I really want to thank particularly the technical staff in the Surgical Skills Lab for all the work that they put in to make this course so successful, and the feedback has been very positive. So as well as in the Surgical Skills Lab, in the endoscopy room, we've been focusing a lot on how to make the training environment better, encouraging people to use magnetic imagers such as the scope guide to improve the ability to train colonoscopy, and also our Train the Trainer courses and colonoscopy excellence course focuses a lot for trainers who aren't familiar with this sort of equipment in terms of giving them the skills and the know-how about how to use equipment like scope guide, and making use of techniques such as water insufflation colonoscopy, which are really becoming more and more established within colonoscopy practice in recent years. So in terms of implementation, and I think this will be a big focus for the discussion this evening, we're hoping that for all of the trainees who's entered the specialist training programs in gastroenterology and general surgery this year, that really from around now that we'll begin the process of getting our trainees registered with the NQI program, beginning the process of delivering DOPS evaluations and offering, for those who have achieved the level of necessary competency, the provisional approval process. For trainees who are in the middle of their training schemes, I think we can begin sort of grandfathering in existing trainees and putting them through the provisional approval process in the next number of months, with the hope that hopefully by the end of this training year, by July of next year, that the majority of our existing trainees will have had the opportunity to apply for, be granted a provisional approval if competency permits. And for year 5+ trainees, so those who are in their penultimate or final year, I think we have to be realistic that we're not going to try and impose this on people who are almost finished their training. But if people do wish, on the basis of their existing training record, to seek a final certification, I think it would be very useful if we can support them in doing that. So the challenges with the training model, well, clearly in a time when we have a big backlog in GI endoscopy, service demands are going to put, I think, significant pressure on the delivery of training. And I think certainly as an endoscopy program, we're very keen, obviously, to do everything we can to deal with the backlog, but training can't be sacrificed. And we do need to make sure that training is part of any solutions that are put on the table to try and deal with the backlog. But clearly there are challenges both from that and also related to the recent cyber attack. That's had a big impact on how we've been able to record QI data in the endoscopy program, and the catch-up process is clearly something that's ongoing, and that may be something that delays our ability to be able to bring people through this provisional approval process in the coming months. The other big challenge is that this, I think, will work very well for our trainees in gastroenterology and in general surgery who are within structured training schemes, but for NCHDs who are outside of training schemes, nurse endoscopists, we really don't have the governance structures to be able to deliver the model fully for those individuals at the moment. But I'd be encouraging anybody outside of training schemes to follow the framework and individual units to deliver training for people outside schemes according to the processes that are outlined in the framework as well. And I think then the other challenges, we need to think of ways to support and recognise our trainers to be able to deliver an ambitious programme like this. But I think it will be something which in the long term will be great for GI endoscopy in Ireland. So I'm going to ask Professor O'Connell, President of RCSI, and I know a very keen colonoscopist himself, and Professor Michael Keane, the Registrar of RCPI, to make a few remarks now on behalf of the two colleges, and then we'll move into the panel discussion. And I'm very pleased to have Professor Kevin Barry from RCSI, Dr. Owen Slattery and Dr. Evelyn O'Toole from the gastroenterology program, training program here in RCPI, to join us for the panel discussion this evening. So we might just move on to I'll stop sharing. And really, I was going to maybe invite Ronan, you to say a few words first.
Good. Thank you, Glenn. And I'm very pleased to be associated with this launch, as is RCSI. As many of us, in fact, I presume all of us here, I grew up doing endoscopy on the See One, Do One, Teach One old model, and competency was determined by longevity and numbers. And surgical training has evolved, and we now are training to capabilities in practice under the new curriculum. And this is an exemplar of how you should do it. That it's not the number, it's not the duration, it is, can you do it safely? and can you do it repeatedly in different scenarios? And so many times surgeons and general surgeons find themselves at nights or weekends faced with GI bleeding, and they've had really minimal training in how to do it. So I think this is something that it's really welcome that the gastroenterology community has embraced the GI surgical community and is sharing the skills that have been acquired and developed by the endoscopy community in past decades. And things don't stay still. I mean, the advances that are being made in endoscopy are truly extraordinary, and I suspect we are facing into the use of artificial intelligence for diagnostic lesions, to diagnose lesions and to give probabilities of malignancy, etc. So we really do need not just to set this framework, but it's a dynamic thing and to grow it. We're very pleased that the two Royal Colleges can collaborate together, and that the facilities of the National Surgical Training Unit in 26 York Street can be available to all of these trainees. Can I just say that I'm very grateful to our surgical colleagues, Ken Mealy, Fiacre Cook and Paul McCormick, who've been part of the committee, and also the two trainees, Aina Ryan and Jessica Ryan, who have also been part of it. Key to this will be training the trainers. We're all for progress. It's just change we can't stand. And I'm afraid the trainers are going to have to be led along this road, because there's no point in putting in a new program and have all these DOPs if we don't know how to do the DOPs. And I think, Glenn, amongst many challenges, I suspect that's going to be the biggest challenge, is training the trainers and getting this streamlined. But I'm delighted to be party to it, and thank you for inviting me.
And thank you very much, Ronan, for your support and those. I think I think a lot of the issues that you've touched on there are absolutely going to be some of the things that make or break the success of this approach in this programme. I'm very pleased to invite my colleague now, Professor Michael Keane, Registrar of the Royal College of Physicians, to make a few remarks as well. Michael's an endoscopist himself, although if you end up in the GI tract, Michael, it's probably more by accident than by design.
That's very true, Glenn, and thank you, and thanks to Ronan for his words also. I'm delighted to be here this evening on behalf of the College of Physicians to participate in the launch of this, what is a very important initiative. I think it's a great collaborative effort between our two colleges. We've talked about competency-based training as opposed to numbers-based for many years, so it's good to actually see it now actually happening. I think it's also great to see the collaboration, because I think it shouldn't matter what the background of the endoscopist is. What is important is that we have competent endoscopists that are interested and skilled. And I think our trainees will benefit greatly. Our trainers will benefit, notwithstanding Ronan's caveats, but I think it will be of benefit to our trainers, and then ultimately it will be of benefit to our patients. So I think this is a great initiative, and delighted to be here this evening.
Michael, thank you very much. And I just want to remind anybody who's joined us this evening that this is very much a mechanism to share information about the framework, but also an invitation to all of you to put forward your questions and comments about this. We want this to be a forum this evening to allow people to raise any questions or concerns that they have. I'm pleased as well to have, obviously, joining our panel discussion this evening, Owen Slattery and Evelyn O'Toole, our National Specialty Directors in gastroenterology. Owen or Evelyn, maybe if I can ask Owen first and then Evelyn next. Do you have any initial sort of comments that you wanted to make, or anything just to add to what's been said already?
Not really. I mean, just to reiterate everything, I suppose, Glenn, that that this probably has been a long time coming, and it's extremely welcome. The previous GI endoscopy curriculum was not particularly well formulated and a little bit ad hoc, I would say. So to bring some true proper structure around this is welcome. And I think in particular, the fact that you've managed to join the two colleges is incredibly important. An old surgical boss of mine said we're all gastroenterologists, just medical and surgical gastroenterologists, and I think that's important. We bring slightly different skill sets to the table, but we all do the same work. So I think this is wonderful. I think it's going to really empower and embolden our future trainees as they go on their future careers in gastroenterology and surgery. And it puts us, I think, in many ways ahead of many of the leaders in the field in training and endoscopy internationally, actually. So well done. This is a strong body of work, and I fully support and endorse it.
It was very interesting on the GI bleeding course we ran recently, just a few weekends ago, that when the course opened, we had it was like the goats and the sheep. The gastroenterology trainees all sort of stood at one side of the room, and the surgical trainees all stood at the other. But actually, by the end of the day, because we had everybody working together in small groups and we mixed the groups, it was very, very nice to see, even over the course of just a single day, how people started to come together and to mix, and I think that sort of collaborative relationship within this sort of training framework will be something which will greatly enhance patient care, because I think a combined approach to patient management is something we all recognise as being very valuable for patients with a whole range of GI diseases. Evelyn, did you want to come in just to add anything to what to what Owen had to say from the point of view of our trainees? I think you're. Oh yeah, you're muted there, Evelyn. But
I've got also. First of all, massive congratulations on the new study days. The feedback from the GI bleeding course from the SBOs was fantastic, and I think the polypectomy one will be really welcomed. I guess just on a practical level, I think it's brilliant that we have this competency framework. But I think just when we look at the individual hospitals and individual training units, I think we all have to make sure that this actually happens and that people are still trained. And it's one thing having a document. We all know in every hospital in the country where we have SBOs, gastro SBOs and surgical SBOs, there's still people on their own given a scope and told to crack on. So I guess if we're taking this quite seriously, I know we discussed at the STC there after the last ISG that really we have to make a concerted effort to have training lists. Not all hospitals are delivering them. I think if we're going to be adopting this framework, there has to be a serious effort from trainers to actually train the trainees. This has been fed back to me at the assessments recently. Now, obviously, COVID had a massive implication on training, and we've got huge waiting lists, and not every endoscopy list is going to be an opportunity for registered to train. We have to, address what's happening to our list at the moment. But I suppose not every hospital that's getting trainees is providing hands-on training, and I don't know. I know Grace Harkin circulated a survey Monkey last year, just in terms of like what tools patient the registered had for training. Did they have scope guide? Did they have CO2? Did they have all the sort of modalities that we would say are what are required for endoscopy training? And now, thankfully, I think most of the units now are a little bit more up to date and have scope guides and have CO2 and foot pumps, etc. But I guess there's an onus on us if we're accepting SBOs and we're assigned as trainers to make sure that we've got the appropriate equipment within the rooms and that there's actually appropriate trainers to do the training.
No, I think that's a key point, and I think it's something we're going to have to talk about if we're to avoid the possibility that this is a document that just sits on the shelf and it's full of good intentions, but that it doesn't really change things. We are going to have to think seriously about how are we going to assess the implementation, like how are we going to actually look at whether it's happening on the ground. And I think the voice of the trainees is going to be very important in that. So I wanted to ask, I can see Danny has his hand up, but I wanted to welcome Kevin Barry and to ask him to just speak from the perspective of the general surgery training program. Kevin, you've been very supportive to everything we've tried to do, but I wonder what your views are, and in particular how you feel the trainers in general surgery are going to cope with seeing something like this, because I know it's part of a big change within surgical training at the moment in the way the way the curriculum is being structured. So.
Yeah, well, thank you very much, Glenn, and thank you for inviting me to the panel discussion on behalf of my colleagues at the RCSI. The competency framework is very much in keeping with the philosophy of the new curriculum, as our President, Professor O'Connell, just alluded to a few minutes ago. And in terms of skills acquisition, RCSI has a lot of experience in looking at skills acquisition, particularly in laparoscopic surgery. So I think this fits in very well with the new curriculum. This morning, for example, I was reading over the finer print of the new curriculum in general surgery, insofar as it relates to endoscopy, for example. So the competency framework that's being launched this evening is very much in keeping with what's in the new curriculum insofar as what's referenced for endoscopy training. So we would certainly welcome this. I think the trainees will embrace this relatively easily. We have about 60 higher surgical trainees in general surgery. I think the bigger piece of work is to get our trainers to adapt to the assessment forms and to accept them. And obviously this has to become part of the annual ARCP process going forward. I think it's excellent that it's targeted particularly at the trainees in, say, ST3, ST4. And I would also like to say that the STEPS course that you ran recently, the feedback from that was excellent. So thank you very much indeed.
No, that's great, and I think the voice, the trainees are very hungry for face-to-face education at the moment. We ran another virtual course today, and just the level of interaction and engagement is, I think we've all got a bit of Zoom fatigue at this stage. I can see Danny Sherian has his hand up, and I want to invite anybody else who has any comments or questions to make them. But Danny, do you want to say a few things? Danny's a member, I could just say, of our faculty for the colonoscopy excellence course, and works in Beaumont Hospital, which is one of the sites which has been very consistent in delivering the hands-on colonoscopy teaching. So.
Thanks, Glenn. Just very quickly, first of all, congratulations. It's a great initiative, and it's great to see so much enthusiasm from everyone. Sort of following on from what Evelyn said, I think part of the difficulty with training lists is that I don't think we have any standardization as to what a training list is. And along with training the trainers in terms of how to scope, I wonder, should there be some guidance, at least broad guidance, in terms of what a training list should be, how many points, for example, should be on a training list, because we often have been calling training lists just because the consultant is there and cracking through, however many colonoscopies we need to get through. And that may not be conducive to training a first or a second year SPR. And obviously that's going to be very variable depending on the needs and musts of each unit. But I think some guidance from, your group may be helpful in that regard. Yeah.
No, I think that's a very useful piece of feedback. I mean, one thing we've tried to avoid a little bit is maybe to learn a little bit from some of the difficulties that have arisen in the UK when they formalized endoscopy training, was when they put a very rigid structure on what a training list was and what it needed to be defined as. A lot of trainees then found themselves in a situation where they were maybe not getting access to very many training procedures, and were having a lot of trouble maybe getting to that sort of stage where they'd be competent to have the provisional approval and be able to sort of be led off by themselves. So I think, being particularly in the post-COVID world, being creative as well about getting the training opportunities out of even service lists, I think that's part of the professional development for us as trainers, is trying to teach us all how to be more proactive and clever about creating training opportunities, even when we're not in a dedicated training space. But I think a balance between the two is really important. I was going to invite Oscar Trainer. I can see, Oscar, you have your hands up, and I was going to invite you just to come in if you had a comment or a question.
Yeah, I just want to say I think this is a fantastic initiative, Glenn. And on behalf of Surgical Affairs in RCSI, I just want to thank you personally for the vast amount of work that you put into developing this, and for the huge support you've given us in RCSI over the past several years. It has taken a huge amount of work to get it to this stage, and I think we should acknowledge the amount of work that you personally have put in, as well as the rest of your committee, but you, in particularly, the work that you put into this. I don't think we would have got to this stage if it hadn't been for your leadership in this area.
Okay, well, thank you very much, and it's very nice. It's something as you, if you talk to me for any length of time, I'm sure you know, is something I'm quite passionate about trying to do this, and I'm pleased that really to have had such support from people in both colleges to be able to deliver it in this partnership approach. Gareth Horgan, I know I can see your hand is raised, and I was going to invite Gareth to come in as well with. If you wanted to say something, yeah.
Yeah, I mean, one of the things just in the UK about the training lists they were about 2/3 of the full regular list, and just given the waiting lists and trying to get people through that might be a great way to go. But there's workarounds for it. Like an example is I bring people out to my lists in Lockdown where they get one-to-one training. And during the procedures, I'm writing the reports off and consenting the next patient when things are going smooth, so I can get through the same volume of work as I would have been on my own without a trainee. There's kind of ways we can work around it so we're not impacting on waiting lists and stuff like this. We just need to think outside the box. And just even setting up that list is when we talked to our trainees last year, they're saying they'd like a bit more to 1-1. We had to slot out in Lockdown. We brought them out, involved the trainees as well. They often come up with solutions to help us train them as well. So I think it's worth getting more of them hands-on in each unit, how to make it better for them as well, and they'll often come up with good solutions as well.
I'm interested if people feel you know we've done a good job, I think, now in terms of trying to bring together our trainees within the, say for example, the actual training courses, but whether we need to be doing more to actually in the hospital sites themselves bring the trainees together and how we get them training together and learning from us, but learning from each other as well. Roland, did you want to come in?
If I can, Glenn, I think one area that we have to be careful about is that trainees must be given the opportunity to fulfill the criteria necessary. You know, training lists are all well and good, but there's a big service load, and you cannot have a trainee finding himself or herself getting into trouble with the ARCP because they haven't had the opportunity, through no fault of their own, of getting the 4 DOPs that were required for the progression at that various stage. So there is an onus on the training bodies, and I know we take this seriously within the surgical training schemes, and I'm sure you do similarly in the College of Physicians. But you know, time after time, we find that there are certain jobs or certain rotations where the supervision isn't at the level, and there can be difficulties even getting consultant reports back, never mind adopts. So this is an area we need to really make sure it doesn't get us into trouble.
Yeah. I can see Malik Anwar. I just wanted to invite to come in with a comment or a question. Malik?
Yeah, thanks very much, Glenn. I really am very excited, like everybody else, that this has been initiated. I think it was long overdue. But I just want to raise my concern because you have just mentioned that people who are not on the training program, they might not be able to benefit from this certification. As you know yourself, a large number of endoscopy happens in smaller hospitals where we don't have the luxury of having SPRs. but there are a lot of very experienced endoscopists. So I think it's a little bit disappointing, in my opinion, that they will be excluded. What I see endoscopy as is like a driver's license. I don't think it should be linked with the CCST, either in surgery or medicine. Even nurses are getting, certifications. So I think these people should be included. Otherwise, we will have a high, no equality in the quality of endoscopy in different areas of the country. I think we should have a uniform training for all endoscopists who are performing the procedure. So this is just a concern that I wanted to raise. Thank you.
Yeah. It's something we are very mindful of, Malika, and we've had a lot of conversation in the National Training Committee about this very issue, and it applies equally to our trainees, both in medicine and surgery, who are outside of a specialist training program, and also there's a separate issue as well about how the training process for nurse endoscopists, which is let's say another another thorny issue, because of there is a I suppose even at a national level, I think the position of doctors who are clearly engaged in training, but outside of training schemes is something which needs to be addressed. And I think what the message I'd like people to take away is that this competency framework is meant to be inclusive, not exclusive, and so we're certainly very much in the way that training is delivered at a unit level. Because let's face it, endoscopy training it's very hands-on. It is very much something which takes place in the endoscopy room, and in the way individual unit training leads organise and configure training, we would very much see that all trainees should be having everybody who's training in GI endoscopy should be that the structure for training within all our units should be the same. There's a bit of an issue around the governance of the sort of final certification and sign-off sort of process, and I think that is something that we're going to have further discussions and at a national level within the health service itself. The sort of position of doctors outside training schemes does need to be evaluated more carefully. So I see Neil O'Moran is with us as well, who's one of the gastroenterology SPRs. And Neil, would you like to come in with a comment or a question?
Thanks, Glenn. I just wanted to say, yes, from a trainee's perspective, that this is very welcome, and we're looking forward to it to start. I think often endoscopy training can create some anxiety for trainees, and often at times it can be inconsistent or without structure across some centres, and I think possibly causes too much anxiety to trainees. But it's good to have a kind of framework, almost kind of setting out a roadmap for training, moving from the provisional to the independent training. And certainly the courses will be very welcomed. I know that they're always very, very well attended when they're run. And I suppose, but just to reiterate what I think Evelyn was saying as well about training lists, that it does, continue at times to be a problem in certain centres where the training lists are not as structured. I think that again would just to echo what they're saying, that I think important to structure the kind of training list in line with this as well.
Yeah, I think introducing this framework will help. I think create hopefully I suppose an atmosphere where it's harder for, if there are units which aren't really delivering training in that sort of more structured way, it's going to become more difficult for them, I think, to attract trainees and to continue to operate like that. So there's a bit of a culture change as well, and I think there'll always be people and units who are sort of at the forefront, and others that are maybe trailing behind a little bit. There'll be leaders and followers, but hopefully the progress we will see across the country, hopefully. Yeah. I don't know if anyone wants to come in with any final comments or remarks. I think that was some very useful suggestions for me in my position and for the training committee to discuss into the future. There's clearly some important challenges to how we make this work, but I'm glad that there's been such a positive response overall to the launch of the document, and hopefully we'll have the opportunity to engage with individual units and with the various trainee groups as well to bring people up to speed a little bit more as time goes by in the coming months.
Thank you, Glenn. I'll just round up, and you know, I'm delighted to be sort of involved in this, and myself and Glenn started talking about this when we were final year SBRs in Beaumont, and obviously Glenn just kept on driving, and it has delivered this program now, which is, I think, on a par with anything available around the world. I think a lot of in particular, obviously, to thank Glenn and Dorothy and Grace, but also the training committee, who have been very helpful in developing the program. Obviously, also my predecessor, Chris Steele, who, you know, had from the start was very clear the training was as important as developing the services. I'd also like to thank the two colleges. I think it's great that we've met in the middle. It's amazing to be able to utilize the surgical skills lab in RCSI. And I think this is the future. The primary aim here is to improve patient care, to improve our competencies and skills, and improve the training environment and the training experience. So I think hopefully all three will be winners in this program. And obviously a lot of the work will fall on the trainee leads in the two colleges. So I know there will be a little bit more work maybe than there had been previously, but I think this is work that is worth pursuing, and we will aim to support the program will aim to support it in any way we can. So again, thank you all, and hopefully this is just the start. There will be little bumps along the road, but we can work those out. But I think the framework is exactly that. It tells us how we should train, and then we'll keep an eye on how that is going over time. Just to remind everyone, this has been recorded, and Dorothy will be able to send out links to this and to the framework documentation afterwards. So again, thank you all very much, and have a good evening, and we look forward to working with you all in the future.
Okay. Thanks again.
Right, thanks, John. Glenn.
Bye-bye. Thanks, Michael. Thanks, Ronan. Yeah.
Use a host.